Colorado Hospital at Anschutz. Today's Ethics Grand Rounds is co-sponsored by the University of Colorado Hospital Ethics Committee here at Anschutz and also the Center for Bioethics and Humanities. Today we have a very critical and interesting topic. You have a complex case. Who do you call for help? Ethics, palliative care, psychiatry, legal, rest. This is affectionately known as the Ghostbusters Ethics Grand Rounds. Who are you going to call? I am not very tech savvy, so I couldn't bring up the theme song for Ghostbusters, but hopefully you can hear it playing in your head. It's been about a decade since we have done a similar thing, but it was ethics, palliative care, and pain at the first one. And so we have selected a couple cases, and we have an excellent panel representing. Representing ethics is my co-medical director of the Ethics Consult Service, Dr. Kristin Furfari, who's an associate professor. I'm moderating this panel. Dr. Furfari is representing ethics. Representing palliative care is the director of our palliative care service here at Anschutz, Dr. Jeanie Youngwerth. Representing psychiatry is Dr. Rapp, who is the program director of the Consultation-Liaison Fellowship in Psychiatry. Representing legal is Ellie, Bane, who is Associate General Counsel, and representing the REST program is Dondapati Allen. She's also one of our ethics leads, and she's going to represent both REST and moral distress mitigation. Our objectives for today are learners after the hour will be able to identify ethical, palliative care, psychiatric, and legal issues and cases, describe the need for rest debriefs and what they are, and moral distress rounds and what they are, and explain the differences, identify resources available to staff when faced with complex cases. Everyone is muted and video off by protocol. That I don't quite understand, but please put your questions or comments in the chat. It's going to be monitored. So our first case is of an 85-year-old man who was brought to our hospital by ambulance from a nursing home where he was found down. He was discovered to have a ruptured aortic aneurysm, and was in critical condition in the CT ICU. He was cognitively clear, intact at the nursing home, but now lacks capacity. The team used emergency waiver of consent for all the emergency surgery and post-op therapy. The gentleman did survive surgery, and follow-up care includes artificial nutrition by tube as part of the post-op therapy. So scenario A, the nursing home located a MOST form and sent it over. The signature was illegible, and there's no provider phone number provided. The team did contact the nursing home and could not get any information about the circumstances of the MOST form completion. And this is what the MOST form said. MOST stands for Medical Orders for Scope of Treatment for our attendees who are not in Colorado. Part A, yes to CPR. Part B, full treatment. Primary goal to provide life by all medically effective means. Part C, no artificial nutrition by tube. Part D, discussed with section was blank. The team is currently providing nutrition by tube to enhance his recovery. So they think, should we be doing this? So I'm going to ask our panelists, going in order, starting with Dr. Furfari, what should they do about nutrition by tube? And attendees, please put your questions, comments in the chat. Dr. Furfari?
Thanks. So I wanted to start real briefly by talking about what happens when an ethics consult order is placed. just to give a little bit of a high-level summary of what you can expect if you order ethics as a consultant. The biggest take-home point, if nothing else is remembered at the end of this talk, is that absolutely anyone can order an ethics consult. So every single person on this call today who's involved in the care of this patient could order an ethics consult. At university, it's done by an EPIC order. We also have a pager and an email, and I think Jackie will share those numbers at the end. But just wanted to be clear that if this case was a case that you were seeing, that absolutely anyone as a part of the care team could place that ethics consult order. And when that order gets placed, what happens is one of our consultants will respond to the person who placed the order and ask for additional information about the case. And so what we will want from you is just a quick summary, just what Jackie shared with us about the case and about the question or concern that you have. We're not expecting anyone to call us with a very well put together ethics question. You don't need to have your ethics question perfectly formulated in order to call us. If you call us and say, hey, something doesn't feel right and we don't know what to do, that's perfect. So please don't hesitate to call us while trying to formulate a question. Just get us involved. The earlier we're involved, the better. And our process after talking to you is then to do a chart review. So we'll go through the chart, we'll look up the details, and then and I'm sorry, if there's a lot of background noise, they're doing major construction right here. So Jackie, will you let me know if it's too loud and people are having a hard time hearing me? Is it okay right now?
Yes, it's
okay.
Perfect.
Feels like the building's going to come down. Anyway, so we as a team will talk about the case. Our ethics consultation team is multidisciplinary. So we have me as a physician, Jackie as a philosopher, Annie is also a part of our team. We have a researcher and we have a social worker, and then we have some volunteer consultants as well. And so we do that intentionally so that there are multiple different perspectives and lenses using to view the case. And then after we discuss it as a team, we will get back to the person who called the ethics consult with our recommendations. Now, we're different than any other consultant. We're not like your cardiology consultant who's going to tell you exactly what dose of Lasix to prescribe this patient. What we'll do is we'll give you recommendations and an ethical framework to use to guide clinical decision making. But it will not be this is what you do, and then this is what you do, and then this is what you do. It's a guide, and it can be used to help guide decisions, but it's a very different type of recommendation than our other medical services. So in a case like this, I would say the first thing that I think is that using the emergency waiver for proceeding with care was ethically appropriate in this case. We recommend doing that when the decisions are unclear. And what that means is that the team is providing care, erring on the side of preserving life while trying to sort through the other pieces. And so in this case, that seems entirely appropriate to start there to resuscitate this individual using that emergency waiver while trying to sort through this patient's values, preferences, and medical decisions. The second piece of this, and I'm guessing, Ellie, you'll talk more in depth about a MOST form, but just as a quick summary, a MOST form in the state of Colorado is a summary of a patient's preferences regarding life-sustaining treatments. And so you saw there the preferences this patient communicated about CPR, artificial nutrition, life-sustaining preferences. And we look at those as formal medical orders. They travel with the patient from site to site, so from the nursing home to the hospital, and are viewed as formal medical orders. Now, the ethical framework in this case is truly one of hearing the patient's voice, their values, their preferences, what they want done in medical scenarios. And so our hope would be that we would find the patient's voice as much as we could in a variety of ways. At this point, what we have as the patient's voice is that MOST form. The patient themselves cannot speak about what they want. At this point in the scenario, we don't have family, friends, interested parties to speak for them. And so that most form stands out as the patient's preferences as best as we can tell regarding scenarios and end of life. Ethics will often recommend that the primary team try to determine the situation around the most form. So who signed it and in what circumstance. It sounds like in this case that was difficult, but I would say at this point, knowing what we do, to answer your question in a very long-winded way, Jackie, that we would recommend following the most form as the expression of the patient's values and preferences, while also trying to find family, interested parties, support system, and other ways of hearing that patient voice.
Thank you, Dr. Furfari. A question in the chat, were there other advanced directives at the nursing home? No, there were not. Dr. Youngwerth, they call palliative care.
Thank you, Jackie. So the way that you can get a palliative care counsel, just again to do a brief overview, very similar to what Kristin was talking about with ethics, with an important difference. The thing that's similar is that a provider would put a counsel order in Epic, and it's a provider that would do it. That's probably the big difference. Anybody can advocate for a palliative care counsel. However, we do ask that the attending for that patient is aware and agreeable to that consult. And after they put in the order in Epic, we normally will ask that they page or we make a connection with them so that we can have a discussion about the patient. And we want to learn about their perspectives, what they are coming across for why they are reaching out to us in the first place, as well as their medical input about this patient, what they anticipate will happen, their thoughts around prognosis, and anything else that they've kind of uncovered in caring for this patient that may be important for us to learn about. So when palliative care is consulted, our team is an interdisciplinary team of specialists specifically trained in palliative care, and I should say trained and board certified in palliative care. And so we consist of physicians, advanced practice providers, social workers, chaplains. We have care managers, creative art therapists, and volunteers. And we try to put as many disciplines together when we are doing a consult as possible so that we can have as many different perspectives, listening to, learning about, and being curious about this particular person so that we can learn as much as we can and in a non-biased way as possible. What somebody can expect is that we will set up a time to meet with this person if they are able to communicate. And with this person, since they can't, we'd also make sure that we are trying to locate and involve any potential loved one that this person may have, as well as their healthcare decision maker. And if they don't have one, we will address that during our consult also. And we will basically learn the story of the person. So we want to explore, we want to learn, we want to know this story. When I talk about their story, I'm talking about it even before they got sick. So we want to know who they are as a person, looking for themes that tie their story together through their life, because a lot of times these themes are going to bring out their values. And their values are going to tell us a lot about the things of what matters most to them, what quality of life actually means for this individual, as well as, are there lines in the sand for something when maybe life is something that may not be meaningful or acceptable for them in a certain condition or state of health. And so if we can get this information from them as much as possible, this normally is going to help us to answer anything regarding next steps, because we're going to take their goals of care, which are basically those values about this person. We're going to take what we've learned from the medical team about the medical situation and what we're anticipating medically. We're going to bring those together and then make a recommendation for the next steps that is patient-centered, because it is now aligning with that patient's values. So bringing it to this patient, I probably have more questions than I have as far as an answer or response for next, because I need to learn more. Because I also wonder, this person put down on their most form that they would not want artificial nutrition. I would want to learn more about that. What was that they were thinking about during that time, or, what are those reasons or things that are important for why they selected that, so that we can learn more. Because I think from the medical side, I don't know that that necessarily makes sense when you're trying to recover from a big surgery. Normally, a lot of times having medical nutrition by tube is going to be part of that, particularly from this type of surgery. So again, I want to learn more so that we can kind of sort through next steps in a meaningful way.
Thank you, Dr. Youngwerth. What if you couldn't learn more and you have this tension between wanting everything but nutrition by tube, and that's critical to advance the value of full treatment for recovery? What if we couldn't learn anything more?
We always can learn more. I will tell you that. And in the process of it, we do respect that person's most form in the process of it, unless there's a really good reason not to. And we will always look for ways that we can learn more, and we will do that. And we find ways that we can learn more. So a lot of it's exploring in very creative ways of how we can reach of who knows this person in any way.
Yeah. And there's a lot of comments in the chat. The most form is not technically an advanced directive. It's the medical order that attaches to a thorough discussion about values and preferences. And it's and many people, unfortunately, just use the most form as a form of advanced directive, giving it to the patient directly and having them fill it out. It's my understanding that the most form is the end of that conversation process and filling out of advanced directives, more so to make sure the directives are, the advanced directives are interpreted correctly and acted on. Is that your understanding, Dr. Youngwerth?
Yes. And I think the thing, like you were mentioning too, is most form, for it to be really reflective of that person's values and end-of-life treatment preferences, needs to be done in a meaningful way. When you're filling it out, it really needs to be done where you already have had a value-based goals of care conversation, and now you're able to translate that medically into the orders. Otherwise, it can be misrepresentative unintentionally of that person's wishes.
Yeah. Dr. Rapp, do you have anything to add if they called psychiatry?
So in this particular case, I think that, I don't think that psychiatry has a huge role to play at this point in his care. Let me just kind of describe our team and our consult process as Dr. Furfari and Dr. Youngwerth did. So we are also a multidisciplinary team. We have psychiatrists. We have one psychologist who's kind of dedicated to our general consult team, as well as two more psychologists who are assigned to specific teams, one to the inpatient rehab team and the other to the burn team. We also have a psychiatric nurse practitioner, and we have an LCSW who wears the hat of both therapist and social worker. So when you place a consult order in Epic, kind of similar to the process for other consult services, typically someone will call you to kind of figure out what the best way is that we can help. In the type of case that we are discussing today, These are cases where I think the main role for psychiatry is to help with a capacity assessment. So this patient, again, at this point in his care is, I think he's not able to express any preferences in the moment. We do have this most form, but psychiatry's specialty here is really getting down into the nitty-gritty of a capacity assessment. We do typically, so I've been doing this for a number of years now, and sometimes people have this idea that they're going to place the consult order and psychiatry is going to kind of breeze in and do the capacity assessment and tell them the answer, and that is sometimes the case, but much more often we really need the primary team's help. I used to do capacity assessments kind of without the medical team, and it very, very frequently happens that the patient starts asking questions about their medical care and treatment options that, I may know the general answers, but I'm just not the best person to be answering those questions, or they'll start negotiating, what if I just stay till the weekend? Things like that. Or, what is there an option to do a slightly different kind of surgery? Is there an option to do like a BKA instead of an AK, or just as a random example? And again, I'm just not the right person to be answering those questions. So we typically ask that a member of the primary team kind of come with us to do the capacity assessment, and we kind of facilitate a discussion between that person and the patient about their care and treatment options and what their preferences are. And then we can comment on the patient's capacity to make a particular decision. This is good. I think this is going to become more relevant in the next case. Another thing to remember about decision-making capacity is that it is decision specific. So when we're assessing capacity, we don't assess the patient's global ability to make medical decisions for themselves. It's specific to a particular decision or a particular group of decisions. So again, for this patient at this point in the care, I think it's clear that he doesn't have the ability to make decisions in the moment. However, as he recovers, I think that psychiatry could potentially play a major role in discussing his understanding around what tube feeds are, and how they help, and how they don't help, or like what are the alternatives, what are the implications of declining that. It sounds like we certainly want to respect his wishes, but if he does recover to the point where he's able to kind of have a conversation, then I think it would be worth a conversation with him to kind of make sure that he kind of understands like what is meant by tube feeds, and what role they play in his care. So that's my thoughts on this case at this point.
Great, thank you. Ms. Bane. They call legal.
Oh, great. Yeah, so first, while I think I am a cool lawyer, the glasses are because I got my eyes dilated and I neglected to figure out the time of that part. Anyway, so the process in which legal is consulted, usually I work really, really closely with social work, case management, risk, Jackie and her team. Dr. Youngwerth and I talk frequently as well. And so usually we all kind of collaborate on the cases as they arise. In terms of timing, really, I say I have a really terrible work-life balance, and so a legal consult is pretty much available anytime, which isn't great, but that's what it is. I usually try to, especially when we're talking about decisional capacity, end-of-life issues, usually try to get to those as quickly as possible. So I've seen a couple of comments come through the chat, and I just wanted to address those really quickly with respect to this case. So the first is that when we're talking about a MOST form, an NDPOA, any type of advanced living document, those documents and their validity and veracity are to be determined by legal. Those are not questions that we expect or want our care providers to be determining. So usually what will come up is, for instance, social work or case management might bring something to my attention. Hey, can you take a look at this? It's missing some of the elements that we would normally see. And then I will do an analysis of whether it meets enough of the statutory requirements to be considered valid. So we would never ask you to determine that on your own, nor would we want you to do that. In terms of receiving this case and evaluating the case, my first question is always as to capacity. Does the patient have capacity? At this point, the patient did not have capacity because of how he was brought in, and it was an emergency situation, and so we did not at that point have the MOST form. Typically, when we're talking about a patient being transferred that we know about, typically MOST forms they travel with the patient. So we should have known, but we didn't. And so on this case, the bell on the nutrition had been rung. Makes it really hard to unring it, but it was very clear as to what that form prescribed. In terms of capacity and who can determine it, I do want to echo what the other panelist has said. It does not need to be a behavioral health provider. By statute and by our policy, it is an attending physician or an APN in consultation with that physician via phone, electronic, or other means. So it can be whatever that treating physician is. Now, there are certain situations where they might want to call Dr. Rapp and her team, but anyway, those are capacity. So once we validate what the document was, and one of the other questions that I will ask is, do we have any concerns that the patient lacked capacity at the time the document was drafted or was under some type of coercion or duress? And if we don't know, then we have what I would term a prima facie valid document, then we're going to consider that to be a valid document, an expression of what the patient's wishes were at the time in which they had capacity. And we're going to do everything we can to confirm those patient wishes and to act in accordance with them. One of the problems with the MOST form is that it is supposed to be exactly like Dr. Glover said, like after it is supposed to be a conversation between a patient and their treating physician. It's supposed to talk about all types of different scenarios. What it ends up being oftentimes is a very cursory document about, I want this, but then what I say in section B or C might directly conflict with what I said in section A. So then we need to think about, well, the patient took that additional time to mark no nutrition. That required an active, affirmative action. And so we needed to, in my perspective, from a legal position, we needed to validate what was in that MOST form. From a provider perspective, it's important to note that state law protects providers from criminal and civil prosecution to the extent that you are acting in accordance with a advanced directive, a most form, a living will, those types of documents, as long as you're acting in accordance with those and we feel them to be valid, you're going to be protected. So you don't need to say, oh gosh, what am I going to do now? Am I going to have coverage? Because we will always cover you, and state law is going to protect you from that. So in this situation, my legal guidance to the team was that now we know that there's a most form. I've determined that most form to be a valid legal document. It meets enough of the statutory requirements. The patient indicated that they did not want nutrition by tube, and so we need to cease that nutrition.
Thank you. Dr. Rapp, you have a comment?
Yes, thank you. I wanted to respond to the comment that someone put in the chat that I think is an extremely good point, that you don't need to be a psychiatrist to assess capacity. And in fact, you know, as I said, psychiatrists typically are not in a good position to kind of independently assess capacity. A provider, any specialty can do a capacity assessment. However, I have found that providers in other specialties are very often not trained to do this. So I see psychiatry's role really as we're sort of the process consultants. We have a lot of experience, and we are trained in the process of assessing capacity. What we need from the primary team is the kind of the content. So that's how I think psychiatry is best seen in the context of a capacity assessment.
Or if there's an underlying psychiatric condition that you can speak to the underlying condition of depression or an eating disorder, right? Yeah.
Sure. I think, you know, capacity questions often become more complicated when there is a psychiatric illness and there's a question of whether that illness is affecting the patient's decision-making capacity, or whether their decision-making is sort of is kind of independent of the psychiatric illness.
Thank you. So they stopped the nutrition, and the nurses are asking, what? We're doing everything but nutrition? Why? What are we doing? And they page you, or they enter a rest request. Chaplain Annie.
Thanks, Jackie. So REST stands for Resiliency Education Support Training. It is a multidisciplinary team of staff that volunteer their time to provide one-to-one staff support and team debriefs as well. So the way that you put a REST submission is currently under our RL safety platform, and the option that staff and providers can choose is the peer support drop down, and that will then take you to a short form. It doesn't take more than about a minute to fill this out, and staff have an opportunity to provide a little bit of context for the event that was distressing. So we do have a callback number that they can provide, an email address that we have, and so once that submission is provided, it goes into our REST mailbox, and that is monitored. I do that so we get a report every day for all of the submissions that have come in. Once we see the submission, I'm paying attention to whether staff or providers are looking for one-to-one support. If they are, then I will call them at a time that they've indicated. If they're working night shifts, we try not to call them at 9 o'clock in the morning. So just try to be thoughtful about that, and try to do an initial conversation to just see where they are, how are they doing. And so there's a little bit of processing of the event that could happen in that first phone call, but primarily my effort is to let them know that one, just thanking them for putting the submission in, because we do want staff and providers to self-report when they have emotional distress around an event. It does not matter how big the impact is or how small it is, because in my view, there's no such thing. And just the fact that you're impacted by this is really helpful for us to know. So we then set up a time to do a more structured debrief. I think of it as a structured debrief versus a formal debrief, because formal tends to kind of be a little confusing. What does an informal debrief look like? And so a structured time is simply so that we can actually talk about the event. We can assess how the person is doing, how are they coping, how is this showing up for you at work, outside of work, what other tools do you need? Do you need first call? Do you need some other resources? So that's what we're really trying to find out. So when we talk to that individual staff or provider, we set up a time to meet. We can do it on Teams. We can do it in person if they choose to. And then we go from there. We typically don't do more than one session with them. We really want them to kind of utilize other resources that are available. If the request is for a team debrief, then I would reach out to the manager. They give us multiple times and days that work for the unit. We always make sure that we offer at least 2 sessions to make sure that the day and the night shift is able to attend the debriefs. And then 2 facilitators, a lead and a co-lead, will facilitate that debrief. And if they need more than 1 session, then we're happy to do that.
Can you say a word about what if it involves moral distress?
Yes. So REST debriefs are really looking at, think of it as emotional processing of an adverse event, or it could be workplace stressors, so on and so forth. So it could be one particular event, it could be just cumulative stressors from healthcare. Moral distress rounds, on the other hand, are really asking the question, what is morally distressing about this particular event, this particular adverse event that has happened? And when we do moral distress rounds, once again, this is through the ethics consult service, and we reach out to the manager, we set up moral distress rounds. They then set up the team's meeting in person, whatever that looks like, and then they invite all of the people on the team, providers, staff, everyone, to attend that particular session. Moral distress rounds is asking what's morally distressing, and to really help the staff think about moral distress can happen when our deeply held values feel violated. So helping them name what those violations could be, and also asking, what can you do differently right now at the bedside, at a unit level, at an organizational level, and helping them then actually do some course correction, so to speak, and problem solve in real time.
Thank you. Well, as could be expected without any nutrition, his condition worsens. They call again. Dr. Furfari, do they have to do CPR?
So, I mean, again, my answer is guided by patient preferences, and as best as we can tell in this situation at this point, our documentation of patient preferences is the most form. So again, the ethical framework would be to follow the most form as a reflection of patient autonomy.
What about professional integrity and providing potentially non-beneficial interventions?
Absolutely. So I think that's a really good question, Jackie. We talk a lot in the ethical world about, from a professional integrity standpoint, about allowing healthcare professionals to decide what interventions are appropriate and which are not. So certainly we want to respect a patient's autonomy in scenarios about their own care. We want patients to be able to make those decisions. That doesn't mean that healthcare providers have to offer interventions that are considered to be non-beneficial or not medically appropriate. So, for example, a patient who wants, this is a silly example, but, comes in saying amputate my big toe because it's ugly, right? That's autonomy, patient's autonomy. Patient's preferences are to have this intervention done. That does not mean that the healthcare professionals have to do that just because the patient is asking for it. So there is a component of professional integrity in this scenario. The university does have a policy, a non-beneficial intervention policy that can guide care decisions when the healthcare team believes that they are being asked to do medical interventions that they consider to be non-beneficial. In my experience, it's fairly rare that that policy really gets used. As Jeanie was talking about before, the hope is that with conversation with family members, with support systems of the patients, that we can engage in dialogue to come to some sort of consensus and not have to get to the point of trying to invoke a policy, in which case the providers would say, no, we're not going to do what you want. Hopefully there can be some conversation and consensus and agreement outside of that.
And the most form does say full treatment, but for all medically effective means. And so I'm understanding you to say that the clinical team can say CPR won't work in this situation.
Well, and I think that's one of the challenges with most forms too, is that they can seem somewhat contradictory, and it makes it slightly difficult then to interpret the patient's values by referencing the most form alone. And that's why it's so helpful if there are other, usually people, who can speak about what the patient would want, because the most forms are certainly helpful and can certainly guide decisions. But when it says, CPR, but no nutrition, it really makes it unclear to the care team about what this patient really would want in these scenarios. So I think this is a perfect example of one of those situations that it just doesn't feel great because we don't have that good understanding of what this patient truly would want done, and what their voice would really say if they were able to speak to their wishes.
Dr. Youngwerth, anything to add from palliative care? You've been following this patient through the decline.
I would agree with what Kristin was saying. And again, I would say that, I think in our context, we are pulling in anyone that we can to get to know the patient better. And in that process of it, that can help us to determine reasons why, and that makes sense for this person and their value-based goals of why they may want to be, for instance, a full code and have CPR done, as well as maybe that was done at a time that was very different from now. And if that's the case, we want to learn about that. And if, what would the patient be saying in this scenario that is going on with them now? And that may look very different. And if that's the case, and we are able to kind of help to unravel more about who this person is, what's important, and know in this scenario, maybe they would not want to have CPR, then we'll help to advocate for that and to incorporate that into their plan also.
Ellie, they call you. Do they have to do CPR?
They did call me, and I said the same thing that Dr. Furfari did, which is it's in the most form. To the extent that it can provide any beneficial treatment, we need to provide that. And at a point in time where that type of care is no longer contributing, then we need to have another conversation, because we certainly don't want to just continue a cycle. And because of how this patient had filled it out, we were going to reach that point at some time. And I should also mention, I think a lot of times when folks call, especially on legal, I don't know so much on ethics, I think ultimately people know the answer. They just want somebody else to say, yes, you are correct. And I think it's really hard, especially in end of life cases, because patients have made a decision that feels not great for a lot of our clinicians, because our clinicians are compassionate and they want to do everything they can. But we also need to remember that patients have the autonomy to make those decisions, and all we're doing is we are effectuating a decision they've already made. So, you know, when and if CPR stops, that's not us stopping it. That's us validating what the patient had already said at some point previously.
Thank you. How about this scenario? Forget the first one, except for the medical conditions. In scenario B, this gentleman has an involved family who wants to transition to comfort care based on recent discussions with the patient. But they all say he has a living will. Here it is. He completed it over 10 years ago. It indicates waiting 5 days before withdrawing life-sustaining interventions. The family is troubled. They don't want to wait. What should the team do in this situation? Do they have to wait 5 days? Kristin?
Okay, well, I'm going to foreshadow this a little bit and say that there are definitely circumstances where the ethical framework may not fully align with the legal framework. And this is why we love having Ellie as a part of our process. And so I would say in this situation, again, going back to that ethical framework of hearing the patient's voice from any source possible, we have families saying that they had recent conversations with the patient, and this is what the patient would want. And so from an ethical standpoint, we would say that it could be ethically justifiable using that information to withdraw life-sustaining interventions as a reflection of patient autonomy. I want to turn it over to Ellie next, because I think it will be helpful to hear that the legal perspective might look slightly different.
Sure. So it's slightly different, but not ultimately different, I don't think. So I do try to stay as close to valid appearing documents as possible. However, there are times in which, and I will ask a series of questions, and I should also say every case is going to be different. So if you're hearing us say something on this case and you have a similar case in the future, please still call the ethics consult service, because there may be very different fact scenarios and we need to walk through that. If we have agreement from all interested parties, family, friends, everyone agrees this is what the patient would want, and I have agreement from my care team that says this patient, whether we wait 5 days or 3 days, prognosis is the same. There is going to be no improvement. All we're doing is we are prolonging suffering. I'm not going to then force our care team to continue it for exactly 5 days, right? That doesn't benefit anyone. It's not benefiting the patient. It doesn't support what the patient wanted, and everyone's in agreement. If there was disagreement amongst the parties, then I would likely wait. I would likely counsel the providers to wait the full 5 days. But one of the things that I would go through is kind of, you know, what are our job is as a healthcare facility, right, is to treat and diagnose. And if we're kind of at the end of that, there's really not more that we can do. So on this situation, I probably would have said my legal advice is that you can, as long as everyone is in agreement, you can go ahead and move the patient to withdraw the life-sustaining interventions.
Thank you. How about case 2? We have a 67-year-old man with complex medical condition, diabetes, high blood pressure, had a previous stroke, end-stage kidney disease, on dialysis. He's having difficulty getting to dialysis appointments. The current hospitalization was due to skipping dialysis. He has housing insecurity, and he actually lives in his car with his brother. He wants to discharge to the car with his brother, and his capacity is unclear. He has appointed his brother, his medical power of attorney agent. The brother himself has an alcohol use disorder, and he relies on the patient for housing and income. And the brother also wants patients to discharge. I'm going to start with Dr. Rapp. What should, if if the team calls psychiatry saying, I don't know if the patient has capacity, I don't know if his medical power of attorney has capacity, can you help us?
Absolutely. So this is a great example of a case where I think that psychiatry could be really helpful. So the patient's capacity to make the decision to discharge AMA is unclear. So one question that I have for the medical team here is, what are you recommending? So let's say that they're recommending, so they are recommending ongoing hospitalization, but what are we actually doing during this hospitalization? Sometimes people call with questions about patients' capacity to decline interventions, such as dialysis or chemotherapy, radiation, kind of things that require kind of ongoing patient participation. And my question with those is, let's say that I come in and I assist with the capacity assessment, and we decide that the patient does not have capacity to refuse that intervention. What are the implications there? Like, you can't force someone to have, you can't force a dialysis dependent patient to go to dialysis forever. You can't, even aside from ethical issues with, forcing someone to get, chemotherapy or radiation, it's not logistically possible to force someone to get those interventions. So, I think that part of the concern for this patient isn't just what's going on with him medically acutely, it's his ability to attend dialysis sessions as an outpatient. So part of the discussion here, which isn't even necessarily like specifically a capacity question, is, does the patient understand the medical implications of missing dialysis sessions? Can we help him put together a plan to be more consistent about making it to dialysis? I think, those are the larger questions here. And so that's what makes this discharge very complicated. Whether the patient has capacity to decline any further like acute interventions that the medical team has planned and leave AMA, I think is a much more straightforward question to answer. There are very specific criteria for decision-making capacity that are described extensively in the medical literature, and we would be able to help the team assess whether the patient is able to demonstrate decision-making capacity for those specific decisions. The second question is about kind of the brother and his ability to make decisions. So we don't assess the decision-making capacity of an MDPOA or surrogate decision maker in the same way that we assess the sort of formal decision-making capacity of a patient. But we can certainly be involved in a discussion with the decision maker of the proposed interventions, and I think it can be a very, very similar conversation. That we just don't sort of document formal, decision-making capacity in the same way that we do when we're assessing a patient. Yeah. I think, in this case, the brother, there are some questions about whether the brother has sort of ulterior motives for wanting the patient to discharge. I think sitting down and discussing the situation extensively with the brother could not necessarily establish definitively whether he has the patient's best interest in mind, but would really give us a sense of what he's basing his decisions on. And, we'd be able to see sort of his level of concern for his brother and kind of how engaged he is with the discussion. Ultimately, this case comes down to, and in real life came down to, kind of sitting down with all parties and kind of negotiating a kind of best path forward that was consistent with the patient's values.
Dr. Furfari, what's the ethical framework in this case, if they call ethics?
Hey, in 4 minutes or less.
Yes.
So,
Sorry.
I think exactly along the lines that Erica was speaking to, trying to hear patient preferences, trying to understand the context here, I think is so compelling. It was very interesting in this case that this living arrangement had been ongoing for years leading up into this hospitalization. Patient and brother lived together in the car. That was what they both wanted. And we talked a little bit about the benefit harm scenario here, that it could be potentially harmful to the patient to remove him from his environment that he'd previously been living in, to remove him from his support system, which was his brother, and to place him in potentially a facility that he didn't want to be in. And so recognizing that balance of harm benefit, for the patient and in the broader scenario. Now, the other thing we think about from an ethical standpoint is what we call a safe enough discharge framework, recognizing that when we discharge patients, it's not always the perfect discharge scenario that we would hope for, and that what patients want is not always what we want. But we look at a framework to guide a discharge to recognize whether all the elements are in place to make it as safe as possible. And so the things that we consider in that are the clinical piece, which is not our lane, but is the patient medically ready for discharge? Is the environment able to meet the needs of the patient as best as able? So things like home health or resources to support the patient outside of the hospital. The third one, which maybe should be first, is respecting the patient's preferences. And so are we discharging in a way that is respectful to patients' preferences? And then the fourth element is a broader sensitivity to the societal issues. So things like, are we discharging a patient who has COVID out into an environment where they have potential to harm others? Thinking about the cost, the justice piece of this to the broader system and structure level. And so ethics is helpful when there's a discharge that has some questions about whether, is this really okay? It doesn't feel like the perfect one that we want, but is this okay to discharge in this way?
Yeah. And so also in all of these cases, social work can be consulted for finding proxies and other critical needs of the patient, and spiritual care services for grief reactions and the like, and supporting the staff. So the key take-home point is, if you have a question, call someone. We work together and we will recommend others as appropriate. Here's the summary of how to get in touch with people. Ethics, palliative care, psychiatry, legal. Here's Ellie Bane's email and office phone. And rest is, seems like a daunting a barrier, but you can always appeal to spiritual care and ask, how do I get a rest debrief, and some assistance there. Thank you for your questions and comments in the chat. I've been seeing that people on the panel have been answering the questions. Couldn't have worked out better. Our next ethics grand rounds is Thursday, February 9th, and my colleague, Reverend Julie Sweeney, will be back moderating some speakers on how do you respectfully take care of patients with disabilities and really take care of them, fill their needs, and in a respectful way. That's Thursday, February 9th at noon. Thank you all for your participation. This has been recorded and is available on the center's website, coloradobioethics.org, and will be available soon. So thank you all. Thank you. Help me thank the panel for a wonderful discussion of the many resources available here at Anschutz, and I hopefully for you people in other areas, other parts of the system in other states, for perhaps. So thank you very much for your attendance at Ethics Grand Rounds.